Hello, everyone. Today we will have a discussion on 5-fluorouracil induced cardiotoxicity. We will start understanding this cardiotoxicity with a case scenario. Here is a 60-year-old gentleman who is a known diabetic hypertensive, was diagnosed with third stage adenocarcinoma sigmoid colon, post left hemicolectomy a month back. Then he was planned for adjuvant chemotherapy with FOLFOX. He was started on first cycle of FOLFOX chemotherapy through a PICC infusion. So on the same day, after uh, completing oxaliplatin leucovorin and starting on 5-fluorouracil, he was discharged from the daycare. And then on the same day night, the patient returns to the emergency with chest pain, shortness of breath, and sweating. On examination, the patient was in respiratory distress, has tachycardia, blood pressure 80/60, muffled heart sounds. A provisional diagnosis of 5-fluorouracil-induced cardiotoxicity was made, and the 5-fluorouracil infusion was immediately stopped. Well, as a treating doctor, what are the questions which I have in my mind with respect to a 5-fluorouracil-induced cardiotoxicity? Number one, well, how common is this cardiotoxicity? If there is cardiotoxicity, what is the conversion to mortality? Did his elderly age and his comorbidities like diabetes and hypertension put him at a greater risk? Well, did oxaliplatin and leucovorin, which was administered before starting 5-FU, increase the risk of this cardiac event? Would a smaller dose of 5-fluorouracil would have made it safer? Well, to establish the diagnosis of cardiotoxicity, should we do a coronary angiography in this particular scenario? After recovery from this particular event, can we re-challenge? If we cannot re-challenge, then what can be the adjuvant therapy for this patient? So these are the usual questions as a treating oncologist I get in my mind. Well, coming on to 5-fluorouracil is one of the most commonly used chemotherapeutic drug in solid tumors. Post anthracyclines and taxanes, this is the third most commonly used drug in solid tumors, and it is the second most cardiotoxic drug next to anthracyclines. However, its cardiotoxicity mechanisms are less well understood, and 5-fluorouracil as a cardiotoxic drug is not that well recognized. Well, it was patented by Dr. Heidelberger in 1957. And we have different ways of giving 5-FU. We have bolus 5-FU, we have infusional 5-FU. We have an infusion of 2 days, 1 day. We have infusion of 5 days, and we also have a infusion of continuous 21 days. So we have all these ways of modulating the 5-FU infusion. Well, let us go into the mechanism of action of 5-fluorouracil. As we all know, 5-fluorouracil is an anti-metabolite. Anti-metabolite means its metabolites will compete with the nucleotides for DNA or RNA synthesis. Well, the moment 5-fluorouracil gets into the system, for example, an IV infusion is given, remember 85% of this gets metabolized by an enzyme DPD, which is mainly present in the GI mucosa and in the liver. And this 85% is converted into a metabolite called FBAL. F-ball is the cardiotoxic metabolite of 5-fluorouracil, and it has not got much of biological activity. So F-ball is a cardiotoxic metabolite, which is obtained from the peripheral degradation of 5-FU by DPD, and 85% of the 5-FU gets metabolite like this. The rest 15%, it gets inside the cell, and then it gets converted to three important active metabolites: the FUTP, FDUTP, FDUMP. Well, if you look into uh, the three active metabolites, and one metabolite, F-ball, is the cardiotoxic metabolite. Well, coming on to these, each metabolite, the FUTP, it inhibits RNA synthesis. F-dump inhibits the enzyme thymidylate synthase. The FDUTP inhibits DNA synthesis. Well, the F-ball, which is produced peripherally, is the cardiotoxic metabolite. Well, then coming on to what is the rationale for prolonged infusion of 5-fluorouracil? Well, if you have a bolus 5-FU being given, its half-life is just 10 to 15 minutes. So, if this particular drug, which is an anti-metabolite, which acts only on the S phase, is given, only a small fraction of these cells gets exposed to this particular drug. Therefore, if you can prolong the infusion over a period of 24 to 48 hours, then you have greater fraction of cells coming on to the S phase and getting exposed to the drug. So this is the same rationale for prolonged infusion like any other antimetabolites like methotrexate, cytarabine, gemcitabine, and so on. So prolonging the infusion, increased fraction of cells getting into the S phase, getting exposed to the 5-fluorouracil, and there will be a better response rate and better efficacy. Well, as we discussed, 5-fluorouracil is the third most common drug used in solid tumors. Its first cardiotoxicity was reported in 1969, and it is the second most common cardiotoxic drug next to anthracyclines. Well, coming on to the incidence of cardiotoxicity with 5-fluorouracil, the incidence is as high as 8%. So, the oral formulation of 5-FU, that is capecitabine, is also equally cardiotoxic. And once you start the infusion, the median time to development of cardiotoxicity is around 12 hours from the start of infusion. Therefore, you need to be very careful on the first day of starting infusion. Whereas if you give a bolus 5-fluorouracil, the incidence of cardiotoxicity is less than 3%. Because if you just give a bolus, the F-ball that is produced doesn't stay in the blood for long. Therefore, the incidence of cardiotoxicity is less than 3% with bolus 5-FU. Well, coming on to the dose, whether less than 600 or more than 1500, this has been compared with 5-fluorouracil, and it has been shown that the cardiotoxicity does not matter depending on the dose of 5-fluorouracil. It is a dose-independent toxicity. Then coming on to the other potential risk factors for cardiotoxicity, we have inconsistent data for pre-existing cardiac disease, elderly age, the presence of DPD mutation, radiation, concomitant radiation. All of these have inconsistent association with 5-FU induced cardiotoxicity. However, if you have given leucovorin before 5FU, or if you have given platinum, either a cisplatin or a oxaliplatin, this is associated with a higher incidence of cardiotoxicity. So we have inconsistent data for majority of the things, but only if you have used platinum or leucovorin before, there is an association with a higher incidence of cardiotoxicity. Well, what is the most probable mechanism of 5FU cardiotoxicity? The most probable postulated mechanism is vasospasm of the coronary arteries. Well, F-bal is the metabolite that is blamed for this. Well, even though we say coronary vasospasm as the cause for the reason for cardiotoxicity, if you look into the regional wall motion abnormalities or the ECG changes, they do not obey the territories of the great vessel circulation. For example, an anterior wall, the right coronary artery, you see a posterior wall or an inferior wall infarction. Similarly, left anterior descending or left circumflex, you see the ECG changes in those corresponding leads. But 5FU cardiotoxicity doesn't obey these territories. Well, if you look into the clinical presentation, the most common clinical presentation is chest pain that starts at around 12 hours of start of infusion. Well, if you do an ECG, you may have ST and T wave changes in only 1/3 of patients. 2D echo showing regional wall motion abnormality or septal hypokinesia is seen again in only 1/3 patients. Biomarkers that is are raised or they're abnormal only in 12%. So only when the amount of ischemia accounts to necrosis, only then you will see a rise in biomarkers. So so what we understand from this is the diagnosis of cardiotoxicity is mainly clinical, and you may not have corresponding ECG, echo, or biomarker findings in majority of patients. Well, if you have ECG changes, for example, a sinus bradycardia or a minimal ST wave changes without any symptom, the significance of this is not known. Probably we need close observation. Well, how do you establish the diagnosis of 5FU induced cardiotoxicity? Well, it is very important to establish the diagnosis, because if you miss this 5FU cardiotoxicity and you continue the infusion, this may result in irreversible cardiac injury or even mortality. Whereas if you overdiagnose the cardiotoxicity, then you may result in premature cessation of this most active drug for GI cancers especially, and you may compromise on cancer-related outcomes. So therefore, we need to establish a proper diagnosis for 5FU cardiotoxicity. Well, there is no definitive test to say that, yes, this is 5FU cardiotoxicity. What all is only clinical. The temporality started the infusion at around 12 hours. There is symptom, especially chest pain, that appeared, and it got rapidly reversed upon stoppage of infusion. And if you rechallenge, it reoccurs. So this is the only temporality is what we can use for establishment diagnosis. There is no single test. None of the investigations say that, yes, this is the cardiotoxicity. Well, if you come across a patient who develops chest pain or other symptoms during 5FU infusion, which usually happens during the first infusion, on the first end, usually at around 12 hours of start of infusion, you must immediately discontinue the drug and start them on conservative anti-anginal therapy, especially aspirin, diltiazem, and nitrates, which help in vasodilatation. Beta blockers are usually avoided because this may result in vasoconstriction because the alpha is left unblocked. So therefore, we usually avoid beta blockers. Well, this cardiotoxicity, if you can promptly recognize early and stop the infusion, it is completely reversible in most of them. Then coming on to the role of coronary angiography in establishing 5-FU cardiotoxicity. Well, we do not routinely perform coronary angiography, and it is not recommended to establish cardiotoxicity in relation to 5-fluorouracil. It should be done only if you're planning to re-challenge with 5-FU again, or if the symptoms do not subside even after stopping 5-fluorouracil. Only in these two scenarios, you would go ahead and do a coronary angiography. Coming on to CT coronary angiography. Well, if you have a patient who has a low risk of pre-existing coronary artery disease, only in this small subset where there is no comorbidity, age is younger, not diabetic, there is no dyslipidemia, or there is no previous coronary artery disease. In these patients, you may avoid invasive coronary angiography and you may perform a CT coronary angiography, and it has a 95% negative predictive value. However, if you find any abnormality on the CT coronary angiography, you must confirm it with a conventional coronary angiography. So to repeat again, in those subset of patients where the anticipated pre-existing coronary artery disease is low, that is in the absence of comorbidities, you may get away, or you may start with a CT coronary angiography. And if it is negative, it has a very high negative predictive value of 95%. If it is positive, then you must confirm it with a conventional coronary angiography. Well, coming on to the conventional coronary angiography, there are three types of results which are possible. You did a conventional coronary angiography and you found no stenosis. That means the patient did not have a pre-existing coronary artery disease. Hence, it is likely due to 5-fluorouracil, and therefore you establish the diagnosis of 5-FU induced cardiotoxicity. Secondly, if you have a critical stenosis, that means there was a pre-existing coronary artery disease. However, 5-FU being a precipitating agent cannot be completely ruled out. So on those occasions, you must revascularize, and if re-challenge is deemed necessary, you can consider a bolus 5-FU. Then coming on to non-criticals, if you have a stenosis that is less than 75%, or that is not accounting to complete blockade of the artery, then there are two possibilities. Then you have to do something called provocative tests. If the provocative tests are positive for ischemia, that means there was a pre-existing coronary artery disease, and then you have to revascularize, and then you may re-challenge with bolus 5-FU with adequate revascularization. If the provocative tests are negative for ischemia, that means there was no pre-existing coronary artery disease, and you will establish the diagnosis of 5-FU cardiotoxicity. So that is about the role of coronary angiography in 5-FU induced cardiotoxicity, only when you want to re-challenge or when the symptoms do not subside even after stopping the drug. Coming on to antineoplastic therapy in a presumed 5-FU cardiotoxicity. So you have three options left. Number one, you may re-challenge with 5-FU again, or you may use non-5-fluorouracil fluoropyrimidine, like a tegafluorouracil or a tipiracil trifluoridine, S1, and so on. Or you may completely avoid fluoropyrimidine and you may use alternative treatments like an irinotecan alone, or a cetuximab, or a bevacizumab-based regimen for colon cancers. Coming on to re-challenge with 5-fluorouracil. Well, if you re-challenge in a patient who has a presumed 5FU cardiotoxicity, the incidence of recurrent rates are 90%, and the mortality is 13%, which is quite high. Well, giving prophylaxis with nitrates or calcium channel blockers are not uniformly effective. Hence, rechallenge is not routinely recommended in practice. Well, if at all, if you want to rechallenge, for example, an adjuvant colon or a CT-RT for a rectum, where you cannot avoid 5FU, even you want the cancer-related outcomes become more important, you need to weigh the risk-benefit ratio in the scenarios. So the two scenarios where the benefit is more than the risk is adjuvant treatment, for example, adjuvant colon cancer or a chemoradiation for a colon cancer or a rectal cancer specifically. Well, what are the strategies that are not proven to be effective? Switching to capecitabine will not help. Dose reduction will not help because the cardiotoxicity is dose independent. And the prophylactic strategies with nitrates or calcium channel blockers, again, they will not help. They are not uniformly effective. Therefore, none of these strategies have proven to be effective. Coming on to what are the things, if at all, if you say that, yes, the rechallenge is important, and if you want to rechallenge, what are the things that you can do? You must start 72 hours before giving 5-fluorouracil with anti-anginal medications like aspirin, diltiazem, and long-acting nitrates. And we usually avoid beta blockers. We need to document a proper consent saying that the recurrence chances quite high, 90%, and a 13% mortality with the infusion of 5FU. You need to have an informed consent documented. You need a cardiologist being there, and then you need to administer under strict cardiac monitoring. And if at all, if you want to rechallenge, you try and use a bolus 5FU. As we saw, the incidence of cardiotoxicity is less than 3%. Well, if symptoms recur even with this bolus, then we must permanently discontinue 5-fluorouracil. Then coming on to the non-5-fluorouracil fluoropyrimidines. Well, as I discussed, if you have 5FU, 85% is metabolized by the DPD enzyme to FBAL, and the rest 15% that gets into the cell is actually active. So these are the medications. FBAL is alpha fluorobeta alanine, which is the cardiotoxic metabolite. So when you have medications like tegafururacil, where uracil is the DPD inhibitor, or you have trifluridine tipiracil, where tipiracil is the DPD inhibitor, or S1, where you have gimercil utercil, where they inhibit DPD. So once they inhibit the DPD, then there is less or almost no formation of FBAL. Therefore, there is less cardiotoxicity. So if you are having an active fluoropyrimidine moiety, along with that, if you have a DPD inhibitor, like a gimercil utercil or a tipiracil or uracil along with tegafur, which inhibit the DPD, then peripherally, the FBAL is not formed. Therefore, the cardiotoxicity comes down to less than 1%. And it also enhances or increases the bioavailability of fluoropyrimidine intracellularly. Therefore, that is the rationale for using these non-5FU based fluoropyrimidines. So these are the three non-5FU fluoropyrimidines available with us. UFT, tegafur, prodrug, uracil, inhibits 5FU degradation. S1, which has tegafur. Gimercil is a DPD inhibitor, and utercil is an intestinal 5FU phosphate inhibitor. Then we have trifluridine tipiracil. DPD inhibition happens due to Tipiracil, in all these situations when DPD is inhibited, FBAL is not formed and there is no cardiotoxicity. However, the inhibition is not complete. Still, you may have a bit of FBAL levels, and that may account to minimal cardiotoxicity of less than 1%. Coming on to how to modify our adjuvant therapy if there is a presumed 5-FU cardiotoxicity. Well, you may use a bolus 5-FU leucovorin, like a Roosevelt Park weekly regimen, or you can use a bolus 5-FU leucovorin oxaliplatin based regimen, or you may use a UFT, which is approved, or S1, again, which is approved. However, the combination of UFT or S1 with oxaliplatin is recommended only in the metastatic setting and not in the adjuvant setting. So when you use this bolus 5-FU, again, 72 hours before, you need to give good anti-anginal prophylaxis. So these are the ways we can look into for adjuvant therapy in a presumed 5-FU induced cardiotoxicity. Coming on to CTRT, the concurrent chemoradiotherapy setting, if it is esophagus, then you can as well choose a non-fluoropyrimidine based regimen like a taxane and a platinum. With pancreas, you can choose gemcitabine. But if at all, if you would consider 5-FU, we would again prefer a bolus 5-FU over an infusional 5-FU. Coming on to an antidote. So we all have been hearing of antidote for toxicity. Here is an antidote. The FUTP is an active metabolite that inhibits the S phase of the cell cycle, inhibits RNA synthesis especially. Well, if you have uridine triacetate, which is an oral drug, which is an antidote, when it is given, it competes with FUTP, and it reduces toxicity and may be used if the cardiotoxicity is not reversible. It becomes more important in other toxicities like myelotoxicity or mucositis or diarrhea. However, this is not yet available with us right now. So, well, to conclude, we can have some final conclusions and take-home messages. Number one, 5-fluorouracil is the second most common cardiotoxic chemotherapy drug. The incidence of cardiotoxicities with the first infusion, it usually happens at 12 hours of start, is around 8%. And the culprit metabolite for cardiotoxicity is FBAL. Chest pain being the most common symptom, and it starts at 12 hours of start of infusion, and the most accepted mechanism is vasospasm. The diagnosis is mainly clinical, and you look into the temporality and reversibility with respect to 5-fluorouracil infusion. The recurrence rates are up to 90%, and the mortality is 13% if you rechallenge. Therefore, rechallenge is not routinely recommended. Coronary angiography is not routinely recommended unless symptoms persist even after it's stopped, or if you are planning to rechallenge. Whenever you plan to rechallenge, you can rechallenge with a bolus 5-FU with an adequate anti-anginal prophylaxis, or you may choose a non-5-FU based fluoropyrimidine like S1, tegaforuracil, or tipiracil trifluridine. I would thank all of you for patient listening.